This evening, we have Mr. Tim Bowers with ChristianaCare. Tim joined the health system in August 2019 as the Director of Infection Prevention and became Vice President of Clinical Effectiveness in November of 2020. Previous to that, his time with ChristianaCare, Mr. Bowers was the Vice President of Performance Improvement at Richmond University Medical Center, Staten Island, New York. He has a BS in Medical Technology from the University of Sciences in Philadelphia and an MS in Health Policy, also from the University of Sciences in Philadelphia. Mr. Bowers, Tim, we'll turn it over to you. Thank you so much for joining us.
Thank you so much. And today is a banner day because this is my last meeting and I've not talked on mute the entire day. So this is just the weird ways that the pandemic has affected us. That is a goal every day. So I'm glad I was able to meet that goal. Thank you very much for the very kind introduction. I'll start sharing my screen. So yeah, Tim Bowers, lab background. So a lot of the things that I think are cool, many people don't get to see every day. So bacteria, viruses, and diseases are kind of where I grew up for college, and it makes you a very interesting person, especially at parties and especially during an infectious disease pandemic. So I will let's try and share my screen. I am. There we go. So it's been a great but interesting almost 2 years that I've been at ChristianaCare. So we had to open up the special isolation unit. We have had a number of Joint Commission, who was our accrediting service, visits to see, just to check under the hood, make sure we're doing everything right. And literally 6 months into my stay at ChristianaCare, we had a full-blown pandemic. So it has been nonstop. And then again in November, I was put in charge of, in addition to infection prevention, quality, safety, and patient and some other aspects of patient safety throughout the organization. So really excited to be able to talk to this group about kind of what has been our life's work over the last year, just a bit. So we're going to go through some kind of what the corona, not just SARS-CoV-2 or COVID-19 is, but the entire family, and how that has kind of generated over the last few years. And then we'll get into some of our current day stuff, and then we'll get into kind of what's next. And to predict what's next, I think is going to be pretty tricky, but I'll try to thread that needle. So thanks again for having me. Any questions, by all means, again, put your questions in the chat. I look forward to answering them. That's really the fun part of these events. So how do we get from the upper left-hand side, which is SARS-CoV-2, this little thing that's giving us so much trouble, and that's an electron micrograph, that turns into, you see the picture of, that is a whiteout pneumonia, those are supposed to be clear. You're supposed to be able to clearly see those ribs on a person in the x-ray on the left-hand side of that second picture. On the right-hand side is that was post-lung transplant. That was what COVID did to somebody's lung. The third picture is a proning method, which is when you're delivering somebody oxygen, you put them on their chest in order to better have the oxygen absorbed, to allow them to ventilate better. And that little contraption over top of their head, I think it was Italy pioneered using that as a way to have a non-invasive way to get ventilation into your lungs. And on the right-hand side is just a full hospital. I think that is a field hospital that was built and is completely full of ICU patients. And this is kind of what it looks like today. These pictures are from, this particular picture is from NPR. I think NPR has got a good COVID tracker. I like green, yellow, and orange, or green, yellow, orange, and red for me, because I'm pretty simple and I like to know what the areas I need to focus are on when I start to look at something. So you can see, as of right now, the Northeast, I think, is a bit of a hot spot, and less so in Hawaii and Guam. If anybody were looking for a place to relocate during the infectious disease pandemic, they seem to be doing pretty well. Not just a United States thing, this is a global pandemic. So you get to see, this is NPR, and it is a little bit larger. It's one of, again, one of my favorite ones, because you get to see relative to other performance, how are things going with the pandemic. So again, we're going to talk about the Coronaviridae, which is the family of coronaviruses. So that we're going to kind of understand which coronaviruses are important, which ones are not. This is SARS-CoV-2, so clearly there should have been a SARS-CoV-1, and we'll talk about that too. We'll talk about the pandemic today, including some treatments and vaccines, so a little bit of vaccine information, a little bit of treatment information. I am not a physician, so I don't typically lean on or really lean into the treatments aspect of COVID-19, though I did ask Dr. Marcy Dries, who's our Chief Infection Prevention Officer and infectious disease physician, to kind of give me some pointers on what to talk about. My wheelhouse, which is transmission and prevention, those two go hand in hand, knowing the two, and then of course going forward. Bit of a nerd slide. For those that love Latin, if you've taken it, good for you. I actually still remember a lot. Yeah, I still remember. I still remember my Latin classes from high school, so it actually pays dividends if you're going to go if you're in the medical field. So the Coronaviridae, the entire family, they're enveloped positive strand RNA viruses. So they're not DNA. It's like RNA is different than DNA, and it's only the positive strand of it, and it's enveloped. It's encased in something. And so I think there are some pictures later of kind of what that looks like. But it just kind of, that's why it goes into the Coronaviridae. Those are the type of viruses that are in that particular family. They infect birds, mammals, and amphibians. And there's actually two families in the Coronaviridae. There's Ledoviridae, and that really is just for frogs. So frogs have their own family of coronaviruses that affects them. That is not jumped over to humans at this point, and I think I'm pretty excited whenever I can say that. Then there's the orthocoronavirinae, and there's a bunch of groups in there. So mainly before 2003, the coronaviruses were just really the common cold, mild respiratory illness, a little bit of GI distress. So there are a number of them, and they're classified as alpha, gamma, delta, and beta. Alpha, gamma, and delta, they infect a variety of animals, and throughout the world, definitely outside the United States, the relationship between humans and non-human species are really a lot different. So in Delaware, I live in South Jersey, depending on where you're driving, you can see some animals pretty quickly. Maybe a person or two has, I know my neighbor has chickens and at least one rooster that's in my backyard, but that's not like that around the world. So viruses that can infect animals can definitely cross over if there's a lot of interconnection between the two. And that's the alpha, gamma, and delta. Pigs, bats, rats, humans, geese, birds, and the beluga whale can also contract a coronavirus. I would love to know how that happens. The beta coronaviruses, though, those are the ones where we have viruses of concern. So the so I'm trying. MERS-CoV is the second word, and MERS-CoV stands for Middle Eastern Respiratory Syndrome coronavirus. And so that was in 2012, and that was in Saudi Arabia. We'll talk about that in a little bit. So that was actually the second coronavirus that caused that was significant for humans. And then there's the other coronaviruses, which is SARS-CoV, which is SARS, the original 2003 China, and then SARS-CoV-2, which we're experiencing right now and continue to experience. I linked two links at the bottom. There's a ton of links in this because I have a lot of sources that I quote from, because I didn't do the original research and I want to give credit to those that did. I typically caution against citing Wikipedia, but for things like when you're going into the families and genus and species of different organisms and viruses, it's kind of it's an okay source as long as you validate it with something else. So apologies for Wikipedia sourcing, but in this particular case, it worked out well. So all the coronaviruses, they cause respiratory infections in human. They range again from largely, mild, a cold, and in the case of COVID, an asymptomatic infection, to severe infections and of course fatalities. And so in chickens, they cause an upper respiratory disease. I've never heard a chicken sneeze, but I'd be interested to see that. In cows and pigs, it's mostly GI distress and diarrhea. And it's important to note that for the entire class, other than COVID-19, there are no vaccines. and no antivirals exist specific for those viruses. And that's kind of the spot that we found ourselves in about a year ago. So SARS-CoV, this is the original one. You see the picture on the right-hand side. I just want to mention that despite 2003 being a number of years before Facebook, there was still a lot of, I'll call, fear-mongering. So I think that it was more the magazines and publications like that were really whipping up a stir around SARS. You would have thought it was crawling across the White House lawn the way that it was covered. It was important. It was incredibly important, but the level of fear that they garnered was very significant. So originally in 2002 in southern China, and then it turned into a global threat in 2003. So the illness, the course, if you get SARS, 2 to 7 days after illness, dry cough. Does that sound a little familiar? With progression to hypoxia, which is low blood oxygen, you may or may not have nausea, vomiting, diarrhea, and transition almost always. I'll say almost always without numbers in front of me, but it was very likely that you transitioned from that dry cough to pneumonia within a week or two. And that was the problem, was people that got sick got incredibly sick, and it was tough to bring them back. It was contagious at the onset of symptoms, but most contagious in the second week of illness. So if you think about somebody who's likely to transition to pneumonia, by the time they're in their second week, they're in the ICU. They're not typically at home. They're not typically in group settings. So a lot of this had to do with individuals who were in the hospital systems that were getting people sick while they were in the hospital, not necessarily at home. And there was no cases that were asymptomatic or pre-symptomatic. So pre-symptomatic is a word, and if I'm saying words that have not been defined for you elsewhere, by all means ask. I'm the king of asking people what that means. I say it over and over and over again. I might as well have it tattooed on my badge at work. So pre-symptomatic means, in the days before you become symptomatic. So I might be asymptomatic today. I'm hopeful. I know that I am hopeful that I didn't get exposed to COVID-19. I'm pretty safe. But if I was exposed and I end up getting symptomatic tomorrow, I wake up tomorrow with one of the symptoms that's classic of COVID, I would have been pre-symptomatic today and pre-symptomatic the day before that. With SARS, with the original SARS-CoV 2002, none of that happened. Infection prevention measures. So standard precautions is kind of protect what you're going to go in there. Protect yourself against what you think you're going to meet when you go in there. I always tell new nurses, and they kind of chuckle. If you have a patient that's incontinent and you're going to go in to turn them, you should probably wear a gown. If you have a patient that's coughing, excessively, this is pre-COVID. If you have a patient that's constantly coughing, wear a mask. You need to protect yourself when you go in there, just in case. So that's standard precautions. Contact precautions are for things that transfer by touch, things like MRSA or what's called C. diff or hospital-associated diarrhea. Those things all transfer by touch. And one that everybody remembers is norovirus. And from the few people that I see on my screen, does anybody know what norovirus is? Just to make sure. It's okay. It's the stomach flu. It is the one where you sit bolt upright 2 o'clock in the morning and you have to use the restroom right now. And there is no stop. There is no collect $200. You are going to where you need to go. So that's the norovirus. It's the stomach flu. That's by touch. So doorknobs and things like that. So the measures for inside the hospital, we would wear a gown, we would wear gloves and things like that if we have something that's contact. And then there's airborne isolation. I actually have a slide after this about that. And that's when things really hang up in the air for a long time. It was a global outbreak. 8,000 people were infected, 774 deaths, but only 8 confirmed cases were in the United States, and all were travel associated. None were fatalities. So despite Newsweek, putting that on the front page, 8 cases, 50 states, none were transmitted here. Thankfully, looking back, but it's not something that really may have garnered that much attention.
Hey, Tim, we've got a question in the chat. Would you say those who were younger were more asymptomatic than those who were older when they contracted COVID?
Good question. So this is SARS. This is 2002. We do have a slide on COVID. I don't think age really, I don't think that they've ever said that age plays a factor in whether or not you are asymptomatic. the likelihood that you will develop significant symptoms and significant problems increases with the number of comorbidities you have, which kind of increases with age. So typically heart failure, your heart's not working all that right, you have high blood pressure, diabetes, a lot of these things happen later in life. But I think once you control for that, asymptomatic doesn't necessarily care what age you are. COVID doesn't really care what age you are. Good question. That's all projectile vomiting. Any other questions from the chat?
Nope, none at the moment.
Awesome. So we talked a little bit, this is a sidebar, isolation PPE. I think we've heard about PPE in the news a lot, and that's personal protective equipment. So for SARS, it was you see the big gown, you see the glove, and then you see that mask that's on, and it says an N95 or higher. We've been educated about N95s, especially early on in the pandemic. And that number means that 95% of all particulates are filtered before it gets to the user. But in order to actually have that number be correct, you actually have to be fit tested. So there's a test that we do. We spray saccharin in the air or bitters in the air. We put that thing on. We seal it around your mouth and in your jaw. And if you have facial hair like me, guess what? It's not an N95. It's just an expensive mask because you're sorry. The hair is preventing that seal from happening. So that seal's got to happen all the way around. And it's really, really important to do that. And so that's the type of mask when you're in airborne isolation that's needed. But it's not just the mask itself. So there's also the airflow. So if you have somebody who has an airborne disease, the classic example is measles. Everybody knows that measles is, well, many people know that measles is one of the most contagious diseases on the face of the planet, and it's because it travels really far in the air. And so if you are in airborne isolation, you have to suck the air out of the room that the person is in, filter it, and then typically we expel it we expel the clean air on top of the hospital, away from where everybody is. And so those two things make up airborne isolation generally. And that's what was required for SARS. It's also what's required for MERS. MERS is thought to have come from camels, though we can't really find a source. It was identified in Saudi Arabia in 2012. And again, 5 to 6 days after exposure is when you would get sick, fever, cough, and shortness of breath. The infection prevention measures were, again, standard contact with the gowns and gloves, and then airborne isolation. That outbreak actually lasted 8 years. It was really a slow burn. Not a lot of cases, 2,521. And I think that gets back to we don't know what the source was for MERS-CoV. We have a few ideas. We can never find that source. 2,500 cases, 866 deaths. So 1 in 4 chance you were going to die if you had MERS. 27 countries almost entirely linked to the Arabian Peninsula, where Saudi Arabia is, except for South Korea. So South Korea had 186 cases, and really, I have a bullet down there. It was one traveler that went to 4 different hospitals and was contagious while at those hospitals, and was in the setting without a mask, in close quarters with individuals. So staff and visitors and other patients became sick. And then since it's 5 to 6 days after exposure, they're discharged from the hospital, they go to a different hospital. So it ended up being, a sizable outbreak, and that was a big learning experience for all of us in hospitals to make sure that we're identifying things early. And it really reinforced a lot of the lessons that we learned in SARS about identifying patients who potentially could be contagious, and making sure that they're segregated. Oh, COVID. Now we're here. So number 3 on our list is COVID. It was identified in the Wuhan province, China. I actually still have the email that we talked about it on January 8th, which is the day after the World Health Organization said, there's this little thing that's happening. 28 patients in Wuhan province, China have developed pneumonia. And that's when, we're at 16 months now for our outbreak response, because we actually started that day not knowing what was going to happen. Again, likely a bat origin, but still we don't know for sure. Symptoms, these are a little bit different, right? So cough, loss of sense of taste and smell, it's called anosmia or ageusia, and also shortness of breath and occasionally some GI, but definitely some headaches, a lot milder than the last 2. Infection prevention measures for this one is actually different. It's not actually airborne all the time. We can make it airborne by things that we do, but it's standard contact and droplet. So not an N95 mask, just a regular surgical mask is fine. Airborne can be an issue in certain things. So for certain activities, we'll talk to that towards the end, but it's really, when you're being loud and you're inside with stale air, not moving very well. And as of right now, 142 million cases, 3 million deaths. In the US, it's 31.6 with over 500,000 Americans dead from SARS-CoV-2. Didn't know we'd be here when we started. I got to tell you that, but that's where we're at today. There's a number of trackers out there to help show how COVID's behaving locally, and I think it's important to use those. So the CDC put up. Yeah.
Do you know, there's a question in the chat. There are two questions in the chat, so this might be a good spot to pause. The first question is, the people who contracted SARS or MERS, did they develop any antibodies that would have protected them from COVID-19?
Good question. I don't know that that's been published, whether or not it's been studied, but that's actually something I'll take back from this. I'm going to say probably not, only because they are different enough to be different species, but that's a good question.
And then the second question is, what is the difference between a standard and a contact infection?
Ah, thank you. Did MERS or SARS confer immunity? Sorry.
No, I like that you're taking notes.
So standard and contact. So standard is you don't know what they have in terms of, in terms of disease prevention. So your regular patient that comes into the ER with a sports injury, right? So they were playing basketball, they twisted their knee or they rolled their ankle. It's bad enough where they have to go to the ER. ER in normal times is not going to wear an N95 in that room, right? So they're coming in for something that's normal. If they have to, if they rolled it so bad that they have to do open it up, they'll use gloves, they'll protect themselves against the person's blood. If they have to go inside their mouth for anything, we're clearly off of the rolled ankle, but if it was like a sore in your mouth that they were looking at, they would wear gloves when touching your mucous membranes. If you're coughing, not knowing whether or not you're flu, they should wear a mask and probably some eye protection. That's standard precautions. But if I know you have MRSA or another bacteria that's really resistant to antibiotics, I'm going to wear a gown because I'm not going to take that out of the room with me because I don't want anybody else to get that. Same thing with C. diff. If you have C. difficile, which is antibiotic associated diarrhea, only bleach kills that. I really don't want that hanging around on my clothes. So I'm going to make sure I wear a gown and gloves and wash my hands and things like that. So standard precautions used to be called universal precautions. And it's just, making sure that if there's blood, you always wear gloves, things like that. If you're going to touch somebody's mouth, always wear gloves. But the contact is, I know that there's something in there and it's probably going to be able to spread if I can't keep it in this room. And so I'm going to wear a gown and gloves, and it's for certain it's for a certain bacteria. If you're inside of a hospital, we actually have a lot of signage. We have a lot of signage in hospitals, but we have specific signs on patients' doors that say contact isolation, droplet isolation, and there's typically some instructions on there. So important if you're visiting a loved one, make sure you're looking at the door for those important keys. We put it on the door because even nurses and physicians sometimes, they're focused on keeping patients well. We have to focus on keeping those. We have to focus on keeping those caregivers well too. So good question about the difference between standard and contact. Hopefully I explained it well enough. So this is how coronaviruses work. And we talked a little bit about the structure of it. So you see the outside, it's called a corona because of the crown that it wears. And it's enveloped, and you see the positive strand RNA out here. It hits your receptor. I could talk about this for days, but I'm going to be quick about it. So this is, and then it comes into the cell. So that it's inside the cell, it actually tells your ribosomes. I'm pointing to the screen as if you could see me. Left-hand side, the ribosome actually does the job and makes a viral polymerase late at night. So that way, the virus itself starts making its own parts. And so it makes that positive strand RNA. It makes the little pieces that will eventually be the corona, the outside, and it goes to work. And so you can see that it goes in two different paths. So it makes the RNA that will eventually curl around and be inside the viral particle. And then it makes all of these little pieces that are blue and green and purple and pink that encompass it and make it another whole virus. And so when that virus gets in, that cell is now a virus making factory. And what it's going to do is it's eventually going to explode because it's not doing its job anymore. And what it explodes is all of the existing viruses that are in there. So some are released and some are just released because the cell eventually dies. Coronaviruses are really good at this, and especially the three that are of concern for us. So if you're a nerd like me and you really like the interior structure of cells, this is the coolest slide of the presentation. Something tells me I'm alone in that, but that's okay. So what's really difference between MERS, SARS, and SARS-CoV-2 or COVID-19? So what is this? Is our ability to detect viral particles in certain specimens. And you can see top left is the SARS-CoV, the original one. Day 0 is the day of symptom onset. And so really barely any virus. And then all of a sudden between the end of week 1, beginning of week 2, huge swell. Same thing for MERS-CoV. Again, really early on, very low, and then a huge swell. Both of those very fatal viruses, right? So even with those small ramp ups until that huge swell for the viral load, still were able to kill between 1 in 3 and 1 in 10 patients that were infected. So even if it did, swell earlier, that patient's actually not going to be around long enough really to infect a lot of other people. Top right, SARS-CoV-2, a ton of virus is available the day that you are symptomatic. So the day you lose that sense of taste, for the last 2 days, you've had some viral particles that have been excreting for you. And this is the reason why you can't just test your way into low numbers for COVID, because the day you realize you've got a positive test, you've been excreting virus for 2 days. It's also not as fatal. So really you're walking around probably feeling crummy, but not necessarily, I need to get to a hospital right now. And that's a huge difference. Those two coming together is for me, the biggest difference between SARS, MERS, and SARS-CoV-2. And really you can see it mimics, that's H1N1 down the bottom. It really mimics how flu works. And if that's like a normal flu, in that, a day or two before symptoms, you're excreting flu, you have a little bit of flu virus that's being shed from you. And so the coronavirus that acts like a flu is a recipe for exactly what we have right now. January 4th, there were 4 countries. The February 15th, there were 28. And I think part of this is just the way that we travel as humans. We crisscross the globe all day, every day. We're good at it. And unfortunately, within 60 days, 165 countries, and I'm sure those 3, 4, or 5 that are down there have had coronavirus now. So 28. I want to make sure that I'm on time. And so, I'll say what happens next is history. This is one of the busiest crossroads in all of Philadelphia. This is by the RP. That's Benjamin Franklin, the Franklin Institute, sorry. And you can see that's 676 that is heading towards us in the distance, completely empty. That doesn't happen. That has never happened in my entire life until this. And it was eerie seeing these photos, but I think it was the right thing to do. Drew Fennell from ChristianaCare calls our shutdowns, because humans shut down, not just Americans, everybody shut down. She called it the greatest act of humanity in our history. And I gotta say, that's probably the best way I've ever heard it explained. Scenes we never thought we'd see. We have the ship in the harbor for New York was one of those moments where, even despite all the things we were seeing, I gasped. I was like, I would have never thought any of this was possible. But also we got to see some of our caregivers, really, all of our caregivers really, but some of them really took a front line role and helped out. That's Heather Farley on the left-hand side, Center for Work-Life Wellbeing, just sprung into action the minute they realized how bad this was getting. They were there for our caregivers. And up and right, our nurses are pretty awesome. And they had they had a tough job, but they really helped each other out, and they had some good morale up there too. FYI, the 2 white masks are N95 masks, and the orange mask is a regular cloth mask, in case you wanted to see what some of those look like. In Dr. Fauci, we trust. That's entirely true. But Dr. Dries is our chief infection preventionist, and she's the one we follow. So typically they agree, almost entirely they agree, but push comes to shove. That's definitely, we're going to follow Dr. Dries, and that's my favorite picture of her. Really a boss looking picture right there, right? She's clearly the one in charge. So a year and 4 months after that first email where we were talking about that this is what the United States looks like as it relates to COVID-19. Darker is higher rates of COVID, and lighter is lower rates of COVID. Tough map to look at, knowing all that we know. It's available. This is Johns Hopkins. If you've not seen the Johns Hopkins site, they have a lot of resources. This is one of my favorite because it gets down to the county level for COVID-19. I see somebody writing it down, so just give me a thumbs up when you've got it. And one of the other things I like to see is in the Northeast, you can see how small our counties are, as opposed to like Wyoming's got like 2 counties.
So Tim, why don't I ask you some questions while people are writing down these links? And just a reminder to everybody, the PowerPoint will be available online once we render the video and everything. So, you know, you don't have to take notes that quickly. Can you get COVID more than one time?
So we have seen, and there were cases as early as, I think, June, maybe June or July, of reinfection. And so early on, back up. So the testing for COVID, especially early on, was really to the genetic level. So we're looking at we're looking for the DNA or the RNA of the virus, which means we can detect it long after it's dead. If you have just pieces of chopped up COVID that are floating through you because your body did a good job of getting rid of it, we can just, that is potentially detectable for weeks to months. And so trying to discern, somebody who has developed spring allergies after having COVID in Thanksgiving, that's real tough. So we do look at a few things. So they look at how long it takes. It's called cycle time or cycle threshold for the test. And so in those particular cases, it's case by case, but it has happened where people have gotten COVID more than once. And now with the occurrence of all of the number of variants of COVID, which is COVID, but kind of a little bit different than COVID. And we have a slide about that later. It is possible to get COVID more than once. And that's a scary proposition.
All right, I have a scarier one for you. Oh, no. Are we prepared to tackle a possible SARS-CoV-3 strain?
I guess it depends. I think I'd like to answer that at the end.
Okay.
Remind me of that though. That's a really good one.
We do have a question of the difference between variants and mutations, but I think you're going to cover that coming up.
Yep.
Are earlier COVIDs likely to stuff your nose until you can't breathe through your nose from time to time?
Earlier COVIDs. So earlier SARS, like SARS and MERS, or are we talking?
I don't know. They just said earlier COVIDs. So
earlier SARS, which is SARS and MERS, much more likely to be pneumonia. So that's not really stuffing your nose. That's if you've ever had pneumonia, and I realize that I'm the only 36-year-old to ever get pneumonia in the summer. It's pretty scary. I'm an endurance athlete. I do triathlon, and I was training for a long one. I guess I was just overtrained and run down, and I could not for a week take a deep breath. And I guess I hadn't realized it. It was building over time, but when I realized it, it was the most frightening thing I had ever been involved in. So they were a lot worse than a stuffy nose. Whereas with COVID, we're seeing the gamut of stuffy nose to ICU level care.
So I'm going to hold off on the other questions because they're about vaccinations. So I feel like you might get to that later. So that's it for now.
Perfect. Thank you so much. I cannot tell you how much I appreciate the help with the chat, because I will get distracted and we'll be here for 2-3 days. So again, left-hand side on this screen, you will see it's again the Johns Hopkins, but I zoomed in on Delaware. We have some struggles. in Delaware, not nearly as struggling as New Jersey or most of the islands of New York. So it's Northeast. Generally, we are packed in like sardines compared to the rest of the country. I am from New Jersey. Well, I live in New Jersey, and we are the most densely populated state in the United States. Not surprising that a respiratory virus spread really, really well there. But it is pretty interesting the way that the outbreak has unfolded, kind of starting north in Wilmington, Middletown, Smyrna, and then towards the summer, really going more towards the beaches where individuals were starting to congregate there, maybe not necessarily as distant as they should be. So these are, the one on the right is actually the map on the right is actually available through DHSS. And Delaware's got a lot of resources on how we're doing. So this is Delaware's COVID experience on the long haul, right? So April 1 to April 20. You can see we've had at least three different waves, and we're on our fourth. So there was the original one, and you get, looking at the average, looking at the blue bars is probably the best way. So the early one in the spring, we had another one towards the end of the summer. It was more of a swell than a surge, but depending on where you were in the country, it was a much larger surge. And then the holidays really, the COVID really went for broke, and really succeeded. So the weeks after Thanksgiving, you could really see that there was a lot of transmission going on. I'm sure nobody meant to get sick or get anybody else sick, but that was the result of human behavior towards that time of the year, really stressing all of our hospitals, our outpatient clinics, our ability to serve those individuals. Delaware, I think we did a much better job than a lot of other states. Some other states, I think Arizona particularly, I think was called out for, they were out of, there was a few states that were out of ICU beds, and they actually had to ship people across state lines in order to get ICU level care. So we were able to manage our resources a little bit better than that. A lot better than that. And so that really started coming down mid-January towards February. And ever since the last probably 4 or 5 weeks, we've started to see that increase again in the spring, the fourth wave. The fourth wave is probably because of a number of things. We made a big deal about vaccines. We have a lot of vaccine, and the vaccines that we use are effective and safe, but they're not. It was not necessarily rolled out as quickly as we had hoped, between supply and some of the logistical issues and making sure that we're doing things equitably. Important to do all that, but it slowed it a little bit. Also, the weather's getting nicer. People are kind of tired of being inside, and so there's the feeling that the vaccines will save the day. And I got to tell you, just like testing, you cannot vaccinate yourself completely out of this. Part of this is still human behavior that we need to keep an eye on. So all of this is kind of, in addition to the spring holidays, all of this is kind of keeping us from seeing low numbers as low as we can. And again, this is Delaware, April 7th to April 20th. You see it's a bit of a steep increase. This is day over day, and again, this is all available on the DHSS websites. I think they do again a good job of keeping up with the data, and that was the last one for this. So it's been an up and down year without a doubt, and without sustained improvement in vaccination rates, in mask wearing and distancing. It's going to be tough to really keep numbers low, to say the least. And I got to say right now, the one thing that I didn't put in here, because it kind of came up today, the United States is the most vaccinated country when it comes to COVID, right? So I think it was announced last week, at least half of all United States adults have received at least one dose of the vaccine. That's phenomenal. That's amazing. That's also one of 200 countries in the world, and one of our much larger countries, India, who's 3 times our size, is seeing positivity rates in the 33%. So 1 out of every 3 people that get tested in India right now is positive. They are a very large country to have that high of a number. So they're not where we're at with vaccination either. 300,000 positive COVID tests yesterday, and so it's a stark reminder that we are not alone. And we are definitely not out of this, although we are making some headway, at least in our country. Treatments and vaccines. So treatments at a glance. I could not talk about treatments without talking about hydrochloroquine, because everybody was talking about hydrochloroquine this time last year. It was the miracle drug. The orders for hydrochloroquine went up like 1,500% overnight when it was mentioned in the media. So unfortunately, it was found to have just about no impact and no efficacy. And really, actually, in some studies showed an increase in mortality. So it's in at least one study, more people died that were taking hydrochloroquine for COVID-19 than the control arm. And that's a recipe for an ended study because you can't continue doing that to people. It's not ethical. So it was suggested as a treatment almost a year ago. And then by the June 15th, the emergency use authorization was withdrawn. So what's emergency use authorization? The FDA will approve drugs for certain reasons with specific data that says that it's safe, then that it's effective, and that and all of this. An emergency use authorization is less than that. And so it's the easy example is AZT for HIV in the late 1980s. Late 1980s, HIV was not a chronic disease. It was killing a lot of people. AZT's trial was found early on to have significant benefit in terms of reducing mortality. So instead of making the drug maker continue their study for another 2 or 3 years to prove, they said, it looks like you're not having any worse outcomes. You're actually having better outcomes. This is safe and effective as we see it today. Continue to study it, but we can give it to these patients because they sorely need it. And so the emergency use authorization, which is what the vaccines have and what any of these treatments would have for COVID, because we just don't have the studies to back up a full approval. Hydrochloroquine, that was recalled pretty quickly. So by June, hydrochloroquine, the FDA said you can't really write a prescription for hydrochloroquine specifically to prevent COVID. And that's probably the biggest indicator that you shouldn't take it. In addition to a number of experts saying that it's not appropriate or not really shown to be effective. And again, all of this down the bottom, you see COVID-19 treatment guidelines.nih.gov. If you Google COVID-19 treatment NIH, that's your first link that pops up. Azithromycin, Z-Pak, which we typically take for our common colds, that was shown to provide no benefit for severe COVID. Zinc, man, if I had a nickel for every time I opened up Facebook and heard about zinc, but there was no studies that show that it's efficacious against COVID-19, and so it's just, you should get zinc through your diet and all that other. Just don't take more than the dietary recommendation of zinc as of right now. Remdesivir, and this is where the names get hard. So remdesivir is approved for hospitalized patients, and so these are all being studied now. But this is one of the drugs that has shown promise to decrease days on ventilation and improve outcomes in the hospital. Bamlanivimab, and that's of those two drugs. That's the only one I can say. Bamlanivimab was a monoclonal antibody, so it's an antibody that is cloned over and over and over again and was given to patient. That and one of 2 other drugs, when those 2 are combined in the outpatient setting, it can actually prevent people from needing to be hospitalized. And so that was really, logistically, that's tough because you really only have a day or 2 to get this drug into the patients in order to keep them out of the hospital. But when you do, it's got a tremendous upside. There's a lot of prevention in that, and so it's tough that the patient got COVID. But if we're able to look at high-risk patients, give them an infusion of this drug, and keep them out of the hospital, that's a win. We need to take that win because we had some pretty sick patients in the hospital. Convalescent plasma, so individuals who have had COVID in the past, we were asking them to donate blood for a long time, and so we were studying that. There's not enough data right now to say whether or not it's working or whether or not it's not. It's just a reminder that the scientific process, it takes a while. And so we're just not seeing the outcomes just yet, but that'll be continued to be studied. And then corticosteroids or steroids, there are specific situations where this applies. There's a number of really interesting things, and it's very transparent in that they list everything that has been done, that they read and that they were able to review to come to their conclusion. And individual physicians may or may not agree, but I think it's important when you look at consensus across individuals that work in the NIH, very important to go by what they say. So they typically don't recommend against, but they will say that it's not recommended, that it has shown no efficacy in order to be recommended for. Vaccines have shown to reduce the likelihood of spread. This is what I think I was trying to say there. 45 slides. I think that's the one line that got by me in proofreading, sorry. But there's no prophylactic treatment outside of vaccination that is recommended to prevent COVID-19 infection. Does anybody know who that person is on the right-hand side? Anybody know the movie? It was one of my favorites before the pandemic. That's Jude Law in Contagion. If you've not seen it, it's a great follow-up to this lecture. I advise popcorn and a decent tea if you're a tea drinker, if you're gonna watch that. It's a good movie, and eerily similar to what we experienced. But his drug was Forsythia, which is a make-believe drug. I won't comment on what has been pushed during this pandemic, but there are a number of things that said, oh, if you take X, Y, or Z, you will definitely not get COVID, unless the words are shelter, vaccine, or a trip on a boat by yourself. There's nothing that's gonna be prophylactic that's been proven to prevent COVID-19 other than the vaccines. So this is Operation Warp Speed. Hopefully you've heard of it. So this was the initial Operation Warp Speed is specifically developed to ask vaccine makers to take risks, and not with outcomes. So the problem with vaccines are, number one, they typically don't make money. And number two, it takes forever to do everything. And by the time you're done, you're all the way through it, you may have a vaccine for something that's no longer a problem. And so what Operation Warp Speed said, the United States government will pay you as long as the product that you make is effective, you can show that it's effective, we will pay all of your upfront costs. We are taking all of that risk off of you. You don't have to try to make money off of this on the back end. And so you go through your initial trials of how do I make this so that it is safe for people to take, and then once it is safe to take, how do we make a safe product that prevents COVID? And in that time, once you have that you can at least scientifically prevent COVID with this vaccine, the United States is saying, produce as much as you can, as fast as you can. And so we will, even if it gets through and it ends up, and we end up not using it, we are going to pay you for everything you just did. And so that's a huge relief. So it's billions of dollars that were spent. And it really, and you can see the timeline here, it didn't even take 16 months. We started it, I think, in March, and we were done. We had shots in arms in December. In 9 months, they were able to do that. And we have a few stories after this about how that was possible. But it is, there's nothing short of amazing of how that went down. And so it's one of the scientific marvels, and one of the reasons I was so proud to be a scientist, not remotely involved in this, just that science could do that. And that's really, really cool. How am I doing on time? I'm trying to make sure I don't, I'll keep going, sorry. So the vaccines, we're looking at Pfizer, BioNTech, and Moderna, both of which are 2 doses. Pfizer was knocked because we had to buy freezers that could go down to like -80 degrees. That's not something we typically have in hospitals, and definitely not something that's easily available for the public. But those were the rules of the game, and we were able to do that. Moderna still needed to be frozen, and also 2 doses. And frozen is better than ultra cold, but still not necessarily something that's easy, both of which are multi-dose vials. And that has to do with our ability to try and vaccinate as many people as we can. And there's no preservative. So once you enter that vial, you've got 6 hours. At 6 hours, if there's anything that's left in there, you got to throw it away, and probably shed a tear doing it too. Johnson & Johnson is a virus vector vaccine. And so it uses an adenovirus, and we'll talk about that in about a second. It's only 1 dose. There's no follow-up needed. It's only refrigeration, but also multi-dose and preservative. So on paper, you know, Johnson & Johnson's the way to go for logistics. So if you have individuals that are tough to get to, you don't think you're going to get them twice, Johnson & Johnson is the one. And we'll talk about the pause too. I couldn't talk about this without doing that. The mRNA vaccine history is really cool. I have the link down the bottom. After you get this presentation, go and read the whole story. I'm sure they probably played up some of the drama, but I really, really thought it was cool. So actually, the mRNA therapy was developed 30 years ago, or the start was developed 30 years ago. We got it to work in mice in 1990, but it took 15 more years for a University of Penn researcher to get it to work in humans. And she literally worked all 15 years being demoted because she couldn't get grants because she wasn't able to prove her theory. But then in 2005, she proved her theory literally 2 years after SARS. And it actually, her discovery helped found Moderna. Moderna saw that and said, we can do a lot of stuff with this, including create embryonic stem cells or create vaccines. And so they actually started with mRNA vaccine work in 2018. So this is a confluence of events that you could not make up for a movie. Pfizer BioNTech is the company that partnered with Pfizer. They actually started as a immunotherapy company and started trying to do a vaccine for cancer using mRNA. So we have 2 companies that are using mRNA specifically for vaccine work. And then COVID comes around and we need vaccines as fast as humanly possible, and definitely not using a live virus. So they were the ones that were able to step up to the call and really did a phenomenal job. Again, go down and read the entire story. Picture on the right hand side, I think. Definitely shout out to, I can't remember her name, for Cataline. And so she was the one that believed in this so much, she literally almost lost her job as a researcher at University of Pennsylvania, believing in this science. So she is the unsung hero of the COVID-19 outbreak response. Viral vector vaccines. It's been used since the 1970s. It's an old technology. It uses a virus that can't replicate to shoot in parts of the virus that we're trying to make antibodies to. And I did that quickly because I knew we had a picture, and pictures are much better than words. So, and that's for me too, so I love that. The right-hand side is mRNA. So we put mRNA strand, so a strand of the genetic material that only creates this one thing that is going to elicit an antibody response. And we inject that into the arm. It goes into the lymphatic system. Your lymph cells see it and say, oh, okay, I need to make antibodies to this. And then in the second shot, you are literally testing it to be like, do you remember this guy? 100 times out of 100, they do remember that guy, and they just start producing those antibodies. And that's why you have that you can have a reaction, or what it feels like a reaction to the vaccine, even though it's just your body creating creating a response to what it knows it's supposed to. Left-hand side, which I think is it's older, but it is still pretty cool. So that's an adenovirus that is killed, that hexagon, 1, 2, 3, 4, 5, 6, but a hexagon with the genetic material in it. And you see that goes into the cell and then does basically the same thing, just by a different method. A word on the J&J pause. So Johnson & Johnson has been asked to pause their rollout. Well, we are pausing Johnson & Johnson's rollout of their vaccine for a few reasons. There have been 6 instances of a clot, and clots are not necessarily all that rare, but this is a very specific clot in the central venous sinus. And so it's a part of the brain where all the blood dumps into, and that's where it's a pretty specific spot to get a clot, and it's only with Johnson & Johnson. And so it appeared about 6 to 13 days after the vaccine. A little bit of context. Number one, it's 6 million doses, almost 7 million doses. We are less than 1 in a million chances. The likelihood of this happening on its own is like 5 in a million. The relative risk of clotting for other things that we do, even though it's a different mechanism, But for birth control, 9 out of 10,000 women will develop a deep vein thrombosis or a clot in one of their big muscles from a number of things. Or in COVID disease, which is really what we should be comparing it to, instead of 1 in a million, it's 20 in half a million. So it's 40 in a million. So you have a 20 times greater chance of getting a clot from this particular virus as opposed to the vaccine. It is probably going to be approved. I don't have any forewarned knowledge to say that, but it was good to take a beat. Let's look at what's going on. Let's look at the numbers and how things are playing out. You know, let's the next 7 or so days play out to see how many more happen, and then make a decision. So the cool thing is that it's ACIP, the American College for Immunization Practices, and they don't work for the government. They actually a lot of times disagree with the government, and they're the ones that give all the recommendations to physicians to say, this is what we need to, this is what we recommend physicians do. Marcy Dries is kind of she's a non-voting member, but she gets to go to those meetings too. So we'll get to, I think Friday, tomorrow is the day that the next meeting is. Transmission and prevention. Stop me if you've heard this one before. Masking, physical distance, vaccination, and hand hygiene. Is there anything new on that? Just want to make sure. I didn't think so. So this has been the same mantra all the time. Physical distancing, keep at least 6 feet away. Outside is better than inside. Masking, I saw for the first time somebody wearing a strainer on their face. An actual wire strainer that I use for my kids' macaroni and cheese. And I was dumbfounded. I'm like, that's not it. Yeah, there we go. That's not it. But outside of strainers, big gaps, valves, a face shield, just a clear face shield, not a mask. That's really our biggest, getting people to wear masks. I care if it's if we are all masked, and then we can start working on bandanas, the bandanas or the tied handkerchiefs or whatever. Just get something over your face. I need something that is not a wire strainer over your face. I will never not show this picture because I was in the next room, and it was a pretty cool event. Perfect mask wearing, by the way. Terrible mask wearing, by the way. My left-hand side, hopefully it's your left-hand side too. You see that big valve on there? That is a COVID get out of jail free card. On the right-hand side, I think I'd wear that on a motorcycle or skiing. That's about it. That is not stopping your droplets from getting out to others. I have seen the one on the left-hand side, and I just kept walking quickly far away. That is not stopping anything. The one on the right, I kind of feel for him. Maybe he was caught out. His last mask, of course I make up these little scenarios. Maybe his last mask tore off his ears and he's like, oh my God, I need something. And so he had rubber bands and a t-shirt. Still not good enough. Appreciate the effort though. But really with prevention, you're looking at how do you mitigate your risk? How do you prevent as much risk as possible while still being able to live? There's no such thing as a zero risk environment anymore. And I'll get to a graph in a hot second that kind of lays out what's better and what's worse in terms of risk. Just important, we talked about this before, it's transmitted through respiratory droplets. The person may or may not have symptoms. The person may be close to you within 6 feet, or if you're like running on a treadmill with no mask, living your life freely, and you are pre-symptomatic with COVID, you are shedding it well further than 6 feet, especially if you're really going and getting it and breathing deep, or if you're laughing at a bar, or if you're at a restaurant talking loud. These are all activities that will spread it further. Well, let's move on. So this is Saskia Popescu, who's from the University of, or she's from Arizona. I don't know if she's with the university, but she's one of the epidemiologists. Phenomenal individual to follow on Twitter for all of her COVID knowledge. Help put this together. Bottom left, lowest risk. Top right, highest risk. You get to see walking outdoors with or without pets. I love that they give you the option. Running or biking alone or with somebody else, very low risk. On the right-hand side, you see watching sports. You see how close they are together. A movie theater or live theater. The closer you get, the more indoors you get, the more people you get in the space, the higher risk it is. One of my favorite. This is one of my favorite things that even I go back to it. Like, where am I at right now in my risk to make sure that I'm managing as much as I can. because my little one's got to play baseball. It's just got to happen. So I have to figure out a way to do it safely. So this is balancing COVID, balancing your risk for COVID. So it's not just what risk, where are you right now and what is the risk around you? What is your individual risk? And if you're going home to an individual that has comorbid conditions that could make COVID worse for them, how is that, how are you going to manage your risk then? And I think it's important to realize that it's not just us. With contagious diseases, it is never just you, it is those that are around you too. So think about, going home to a parent, grandparent, or potentially somebody who's immunocompromised. Really manage your risk closer to the low end than the high end whenever possible. Variants, and when you asked, so there was a few questions about it. This is a much better slide for me. And again, this might be like long down the geek trail, but you can see a lot of stuff on this slide. Left-hand side, far left-hand side at the bottom, January 16, 2021 is really when we started locally and nationally doing a lot more gene sequencing to see what kind of, what type of COVID is circulating here. And a variant comes about because of a mutation. So mutants and variants are similar unless you're talking about X-Men. So X-Men are mutants, but if you're in Marvel, then I think you were called enhanced. Sorry. So mutations, individual mutations cause variants, and variants can then also get more mutations and become a different variant. And so when it becomes important to us is if it then becomes airborne, right? So if we're talking about a droplet within 6 feet generally, but all of a sudden it becomes a variant and now it spreads much, much further, that's important for us to know, because then our strategies change. It's not just social distancing. It is much different. Or if it becomes much more virulent. So if we get a variant that kind of, now it's starting to act closer to MERS or to SARS with those huge death percentages, that's important to know too. Largely right now, it's just making it spread a little bit easier. And you can see that, I'll call it a tan peach bar, goes from almost nothing, 1-2% on January 2021. By the end, on the right-hand side, B117 is the predominating strain that's circulating in the United States right now. And so that's the UK variant. There is also the California variant. There's also the Brazil variant. I'm sure there'll be a number of variants coming out of India. But we keep an eye on them. This is why we do genetic typing, to make sure that we know what's circulating and how it's behaving. Because if it starts behaving badly, we need to be able to change our strategy quickly, keep people safe. Going forward, SARS-CoV-3, right? That was the question I completely avoided earlier. I hope that person's still on. Sorry for taking so long. It depends on how SARS-CoV-3 behaves. We are better prepared now, and I'll say that because the mRNA technology has shown that we can safely and effectively create a vaccine in a short amount of time to coronaviruses. This is assuming SARS-CoV-3 is actually a coronavirus. If it ends up being another mutant flu or a norovirus that just won't go away, that is something that's just a little bit different. But the scientific breakthroughs that we've made this year with producing PPE, with producing viruses, with the scientific method, I think has prepared us well. I don't know that it ends any better than this particular one does, just because year over outbreak over outbreak, they continue to continue to do it right, they being the viruses, but we continue to have an answer for them. So I'm hopeful that if it is something that spreads quickly like SARS-CoV-2, that we're able to match that in some way, shape, or form. And again, I hope it doesn't take another greatest act of humanity in our history to stamp it down, but I'm very hopeful that science can win. I have to think that I'm a scientist. Vaccine boosters. One of the other things about going forward, we saw almost zero flu this year. There were 20 cases of flu in the state of Delaware, which is basically zero. That's a rounding error. And so, maybe masking works. Maybe we mask every flu season. As an infection preventionist, I would love that. As a dad who has to go to 1,000 sports, I don't know that I like that, but from flu prevention, that makes sense. And the reduced capacity environments are becoming less and less common despite increasing case counts. So going forward, the immediate future, looking to other countries to make sure that we can vaccinate them as fast as we vaccinated ourselves, and then trying to find out what normal looks like, because we're still not on the back end of this. And I do apologize, I took like 3 hours longer than I was supposed to. Oh, I got some memes. You can't leave without the memes. One of my favorites that popped up early, it's good. I have too many bots. It's for your own good. Stop touching your face. Like a good neighbor, stay over there. And just hanging around waiting for the end of this pandemic. I see 65 comments up there, so hopefully
I love the memes. I love the memes. All right. So there are still some questions. Do you think that the flu season will be worse next year since there's no data on the most common strands from this year?
Good question. There is data. It says that we didn't have much. So it's always a mathematical equation anyway. I would assume that I'm pretty sure that it's H1N1 and H3N2, the typical strains that circulated in the year prior that were the minimal flu this year. I do worry about, since not many of us were exposed to flu this year, kind of like a waning immunity, especially in those that didn't take the flu vaccine this year. So potentially you could have some of the flu, I'll say worse outcomes with the flu, but something tells me that we will still have some sort of distancing, masking, something next year to kind of combat some of that. But good question. But I'm hopeful that we have a little bit of carryover, and that that we don't get another pandemic on top of a pandemic.
So do you know if there's been any correlation between people getting the annual flu shots and whether or not they're quote unquote immune to COVID?
Yeah, there's not been any crossover. My understanding is that there's not been any crossover between flu and COVID immunity.
So there are a couple questions, will we ever be able to return to normal life, or is this the new normal? How long until the world looks as if COVID never happened? Go ahead, take out your crystal ball.
After SARS, we saw a number of Asian communities continue to mask. And until 2020, that looked weird to Western America, to Western countries. That was not something we did. And I think now we know why. I think masking in some circles will become a little bit more normal. I think that you'll still see them. You'll see them a lot more in the US and in the West than you did before. So I think normal is going to be, it will not be 1999. It will not be 2019 again. I will say in a very long time, if ever. We've learned a lot in this particular pandemic, and I think if we go back then we potentially could be setting ourselves up for SARS-CoV-3. So definitely not. I do not see 2021 being the 2019 that we remember. Maybe 2023. It depends on what COVID decides it wants its relationship with us to be. If it's okay with being seasonal like flu, we could potentially get closer to what we used to be, maybe a little bit more masking. If it wants to stick around and continue to create new variants that spread quickly, it could be closer to what we're doing right now. This could be our newest of normal. I'm not necessarily the most optimistic person to ask this question, so I apologize if I bummed anybody out at the end of the night. But I will wait and see, and I will not count COVID out until we get to near zero.
Cool. So as far as vaccines are concerned, are there any updates regarding, people under the age of 16? Will we need booster shots in 6 months? How long does the vaccination last? Any information like that?
Yeah, so we knew that coronaviruses, the colds, the really mild ones, we had almost no immunity to them before. There was no long-lasting anything, and so that we had a vaccine that currently works. I think we're on 9 months to a year, so it works for at least a year, and every day that it works is a blessing. So we don't know how long it's going to work, again, because this is the first successful mRNA vaccine for a coronavirus, and Incidentally, they found out after the fact the way they designed it, that it happened to work, is the best way to design a vaccine. The carrier that they put it in goes right to your lymphatic system. Do not pass go, do not collect $200, and does exactly what it needs to do. No muss, no fuss, and creates long-lasting immunity. So
you think it's going to be like a game changer?
So if they can get the frozen thing under control, that's going to be the big thing, because nobody's got a -80 freezer. We had to, places had to buy them, and so that will be if they can do that with like room temperature, that will be a game changer, I think. So we may have to do boosters. Maybe, like I said, maybe you get your flu, RSV, and COVID shots every year, and that's good enough. Or maybe this one outlasts the coronavirus. I'm hoping for the latter. I'm probably thinking more of the former. Probably a booster down the line.
Do you know if there's any local participation in post-COVID syndrome research?
Good question. There's a website. I'm taking more notes. There's a website about the different studies, and I don't have it off the top of my head. Post-COVID and post-COVID syndrome, I assume that they mean what is colloquially called long haulers, so individuals that have symptoms long after.
Yep. And there was somebody who put in the chat, I asked you the question whether MERS and SARS were any kind of help against COVID. Apparently there was the MERS DNA vaccine induces immunity and protects from virus challenge in preclinical models. So something.
I'd be very excited if that whatever works, let's make it.
Yeah. So here's an interesting question I hadn't thought of. Do you know if either of the vaccines react or, give extra protection or something to people with sickle cell?
I don't. And this, I don't know that there's extra, I don't know that one group gets anything extra from any of the individual vaccines. I would say if you have a sickle cell physician, which most patients with sickle cell do, definitely go to them. So the individual, I definitely advocate for specific disease states, cancer, hypothyroidism, whatever it might be, heart failure. Go to the physician that you trust and ask them, can I get just any vaccine, or do you think there's one better than another? And then ask about timing, specifically thinking about cancer with surgery and with treatments and things like that, because they're going to know you both, and they're going to know that very specific disease state and how it kind of interacts with the different vaccines. And for breast cancer survivors that are getting their images, if you get your shot on your left side, it will inflame a lymph node on that side. So they will say, don't get it if you're going to, within X amount of time, if you're going to go and get your scans, because it will be, it could throw up a false negative or whatever it might be. So really important to have that great relationship with your primary, and as long as you get it, I'm happy.
Cool. Well, there are more questions, but they were all either answered during your presentation or they were very similar to the ones that I asked you. So that's it. Unless somebody has one that wants to throw in the chat right now. All right, there's one. Do we know how the vaccine impacts those individuals with autoimmune disorders and what the effectiveness is?
Good question. So that came up a lot early. So I think the standard line from those of us that work in vaccine centers is that the only contraindication to vaccine is having a significant life-threatening allergic reaction to the vaccine or one of its components. And so I'm not saying, there's nothing saying you can't get it. And this is, if you're immunocompromised, then I would definitely say, talk it over with your physician. Again, manufacturer, timing, everything is really, really important, but there's nothing that says you can't get it. It just might be timing or manufacturer differences that would make the difference for you.
And I'm going to guess that the answer to this is no, because I'm pretty sure the answer is no, but do you know of any potential long-term side effects of the vaccines yet? I don't think we've had enough time to prove that yet.
Yeah, no, we've not seen, well, so I would say that the only side effects from the vaccine that have been found were those kind of local reactions vasovagal reactions where people faint. My favorite story is that we had somebody just so excited, that the minute the needle went in her arm, she was out like a light. And, you know, you feel bad, but, you know, she woke up just as excited as when she went out, not realizing anything had happened. So those are really the only reactions that we're having with the vaccine. There is the vaccine adverse event reporting system. And so that's how they caught on to the clot issue, the CVST, the central venous sinus thrombosis issue. So, but nothing has come out of theirs yet to say that there's anything other than the clot issue and some of the local reactions early on. But
have we seen any deaths from the vaccine yet?
I've not.
At all?
So there are individuals who have passed that got the vaccine. That being said, none have been linked to the vaccine. And so that's so nothing has come out about that. So
right. Yeah, the thing that most people don't understand is just because something happened after you got the vaccine doesn't necessarily mean that the vaccine is what caused that thing to happen. And
right.
that's the whole point of having theirs, to make sure that, you know, you can figure out what caused the things to happen.
And if you're worried about sense, you know, oh, they're not going to figure it out. 6 clots. They had 6.8 million doses given, and they found they knew about it before the 6th, but they were looking at it, and so, you know, really sensitive to that stuff, especially with all the information going on around vaccines. So very important to feel. I think it's important to feel comfortable because it is a very safe vaccine. You know, I tried to give you a little bit of background with, you know, we've been working on it for 30 years. It's been effective in humans, the technology, since 2005. Like, this is not something that we're like, you know what I'm going to do today. Like, this is not a off the cuff kind of thing. This was a very methodical scientific process that got us to where we're at. And thankful that it did. I did not think we'd ever get a vaccine for this, and that's super stoked.
So I'm going to ask one last question from the chat, because I think it's a nice way to take us out. Is there any way to distinguish COVID-19 from other respiratory illnesses now that we've been doing it for a while?
So if it's cough, no. If it's, you know, runny nose or sneezing, no. There are those general things that and we were like this before COVID. So if you walked into the ER or your doctor's office with a cough and a fever, it's like 13 different things it could have been. If in flu season, we typically thought it was flu, so we would test you for that. Some of the hallmarks of COVID, though, the loss of sense of taste and a loss of sense of smell. That morning coffee doesn't taste like anything. Burn toast. See if you can smell that. Or don't burn toast, but, you know, find that's a pretty good indication. There are a few things that can cause that too. Enteroviruses, other viruses, respiratory viruses can cause that. But in the midst of a COVID pandemic, where that is one of the hallmark symptoms, I would say that is probably a good sign to get a mask, call your physician, and get tested. One of the things that is a hallmark of, you wouldn't know as a patient, but it's called happy hypoxia or hypoxemia. So you're walking around fine, thinking the world is grand, but your blood oxygen levels just keep ticking down, and then all of a sudden it all hits you and you can't compensate, and you end up in the ICU. So that was something that we found early on, that, you know, people were feeling fine, and then you put that pulse oximeter on their finger, and all of a sudden you're showing numbers in the 70s, and it's supposed to be 90 to 98, 99, you know, higher than 95. And you're looking at them like, something's got to be wrong. Nail polish, like, what's wrong here? And it was just the body compensating for that. So you wouldn't know about that, but you would definitely know about the loss of taste, of sense, and smell.
All righty. Well, Tim Bowers, thank you so much for being with us this evening. And folks, next week, for all the moms and sisters and whatnot online, get the guys in your household online too. We're going to hear from Dr. Mihir Shah. He's going to be talking about the importance of prostate screening and the latest in treatment options. And we look forward to seeing you next week. Again, Tim, thank you very much.